short introductions. We're going to do a short overview of what our ECHO is for those who missed our orientation. And then we're going to have the wonderful presentation from Dr. DePetty on the HEARTS model. And we'll have hopefully some time for questions and discussion towards the end, and then we'll share information on our next session. All right, I want to take a moment to briefly introduce myself. My name is Maxine Arena. I'm the new program manager for the Constellation Regional Collaborative. And I wanted to also take this opportunity to first introduce our subject matter experts. They'll introduce their name and their position. I will start off with Jametta.
Good afternoon. My name is Jametta Magwood Golson. Happy to be here. I am working with the Constellation team as the Health Equity Subject Matter Expert.
Thank you. And Dr. DePetty, just a brief, I have a great introduction for you later, so you could be as long as short as you would like.
Well, let's be short so we can.
Yeah.
Because Alyssa's made me promise to be 30 minutes. Thank you, everybody. My name is Don DePetty. I'm here at the University of South Carolina School of Medicine, former dean, and presently I'm the health sciences distinguished professor here at the institution. Been working very, very long in my career in various aspects of hypertension, and most recently in a new population-based approach, which is regional and now globally, called the HEARTS program. And I'm just delighted to be with you.
Great, thank you. One moment, please. All right. My screen froze, so are there any other SMEs that I'm missing at the moment?
Emily.
Emily, oh, there we go. One moment. Hi, Emily. Can you introduce yourself? Yeah.
Hi, good afternoon. I'm Emily Ridley with Prisma Health in Columbia, South Carolina. Nice and hot here today. And subject matter expert in the area. I'm a clinical pharmacist, so working with Constellation Health. Thank you.
Great, thank you. I just got everyone's faces back. Thank you. All right, and then I wanted to just give a moment to our participants. Thank you again for joining us today. And Sydney is monitoring our chat, and we are asking for you to share your name, your organizations, and your position and credentials. We will start with Rebecca.
Hi, I was just typing this in our chat. I am Rebecca Gainey. I am the nurse stroke coordinator here at Novant Health, New Hanover Regional Medical Center in Wilmington, North Carolina.
Great, thank you. And Erica?
Hi, I'm Erica Yorkovich. Rebecca and I work together at NH and HRMC. I'm the post-acute care coordinator for stroke.
Wonderful. Thank you both for joining us.
Thanks for having us.
All right. Next slide, please. All right, just a few friendly reminders, and I think Zoom already did it for us in our introductory video, but we are kindly asking to mute your microphones when not speaking, and we have our chat function that is readily available. And of course, you could raise your hand as well. Sydney will be, again, monitoring our chat. So if there's any questions there, she'll definitely go ahead and share it with the group. And then just a friendly reminder, our sessions will be recorded and uploaded in our YouTube channel. All right, and then for a brief overview of our ECHO series, focused on hypertension and cardiovascular care. It is part of a 5-year cooperative agreement that we were awarded from the CDC. It's part of an innovative approach to improve hypertension and cardiovascular care in minority populations, specifically the non-Hispanic Black population. And it's also going to be addressing social determinants of needs. We have our own health equity subject matter experts, as Jametta mentioned earlier, and that is fully incorporated in not only our ECHO model, but throughout our entire cooperative agreement. The ECHO series is a series that really introduces a community of subject matter experts, community organizations, providers, and it creates an all teach, all learn environment. And it's really a community to strengthen the community clinical linkage. And we're really excited to kick this off. And part of the flow of our ECHO series is you'll have a short presentation from one of our subject matter experts, a didactic presentation, and then we'll have a question and discussion section of the presentation. And participants are encouraged to submit a case review so that our subject matter experts can incorporate that in their presentations. We do not, I believe, have a case review for this presentation at the moment, but Kathleen will take a moment to explain what that case review template and process looks like.
Thank you, Maxine. So the case review template, what we are asking is that if you have a challenging or difficult case, or even an interesting case that you'd like to share with us, and all of the participants, to please go ahead and submit that. We have gone ahead and created a template that's going to help promote the discussions and the recommendations. I will be sharing out that template in an email after the presentation. That email also will contain a link to the recordings and resources. So you'll receive an email that talks a little bit about all of this. But the template basics are your information and the information on the actual, the patient. So you'd be looking for vital signs and medications, comorbidities, and a description of why you find this case so challenging or so interesting that you'd like to share, and get some help or get some recommendations on that. We actually are also offering CME credits. For this, they are the AMA PRA level 1 credits. And they are going to be given through ACCME accreditation through the SMA Corporation. The SMA organization. With that, what we would need you to do is make sure that after the ECHO session is done, you log in through your iECHO, and there will be an option to do a post-survey. Post-session survey. And if you fill that out, then I can go ahead and award 1 credit for each hour that you are part of the ECHO. Are there any questions on that? Nope. Okay, great. Oh, Maxine, you're muted, hon.
We are going to start with Dr. Tepetty's presentation. While Kathleen is pulling up his presentation, please allow me to introduce Dr. Tepetty. He's a dean and distinguished professor at the University of South Carolina School of Medicine. He's also the United States rep and a lead advisor for the Pan American Health Association, also known as PAHO. He does a lot of work with the HEARTS model in the Americas, and he's also an advisor for Prisma Health. He has been spearheading the implementation of HEARTS in the Americas and will be leading us through a presentation on that model. All right, go ahead. I think you're muted.
I got it. It's yelling at me already. See, and it wasn't even a clicker. Good afternoon, everybody, and thank you for having me. It's really an honor to be with you. Let's just go ahead and get started. There's a lot of information. However, I think we can distill it, but it's exciting information. And if my enthusiasm shows, it's because I am. And I don't apologize for that, because what I'm going to share with you, I think, is dramatically different than what we're doing now. Let's talk about why, and then what it is, and and where can we move forward together as a group and a collaborative. And that's exactly why the Constellation Regional Collaborative came about in the first place, particularly to address disparities, as Maxine mentioned. What we're going to be talking about this afternoon is really, we're going to talk about hypertension and pharmacologic treatment, et cetera, but really what we're talking about is change. How in the world do organizations change, even when it's staring them right in the face, that there's objective data that says you must, not should or could, but must. And that's what we're going to be discussing today, is to get us all in the same place if we can, where our mind is open for change and we're ready to accept that change. And we're going to talk about what some of that change will consist of. Well, first, let's look backwards. There's a gentleman by the name of Cotter. I was fortunate enough to be, when I was in Texas, at the University of Texas, to be asked to go to the University of Pennsylvania, to the Wharton School of Business. And I was introduced to this gentleman by slides, not personally. Dr. Cotter is an immense individual from the 70s and 80s. And what he did was he studied organizational change, large organizational change. And he studied the American auto industry and really started looking at what were some of the barriers to change and why the auto industry, our US auto industry, would not change even when it was obvious that it had to. And then developed 8 key points or key steps to initiate that change and to cement that change. And here they are. The number one step that Cotter taught us and proposed and demonstrated that it's absolutely necessary is that leadership must establish a sense of urgency or a burning platform. And they have to shout it from the mountaintops at every single opportunity, including down into the organization, so everybody understands the why. Why change? What's the burning platform? What's the urgency? And then the other 7 steps are shown here, and we can discuss them at other times. They're all interesting. But the first step is why. What's the burning platform and what's the urgency? Next slide, Kathleen. Well, the burning platform for why we're together this afternoon is clear. And that is, the sense of urgency is that not only in the United States, not only in our state, South Carolina and North Carolina, but worldwide, cardiovascular disease now is the leading cause of morbidity and mortality. It's not infectious disease, it's not public health, it's not clean water. All those are important, don't get me wrong. But number one now worldwide is cardiovascular disease. And why is that so important? And why are we discussing hypertension? And we're discussing hypertension because hypertension is the leading risk factor for cardiovascular disease, morbidity, mortality. So if you're going to start somewhere, start with hypertension. All else is important, as we can discuss in future echo series, et cetera, from diabetes to hyperlipidemia to obesity to social determinants, et cetera. Well, how are we doing? And then this is the dismal news. The hypertension control rates, as defined by a blood pressure of less than 140/90 in the United States, is a dismal 45%. And we're going to look at that at a more granular level. Globally, it's 20%. And that's using 140/90. That's despite safe, effective, and affordable pharmacologic treatment for hypertension that is available worldwide. Certainly available in our country, in our state, in our clinics as a high-income country. So what do we need to do? First of all, we have to recognize the burning platform, and then we have to start honest and open discussions regarding the efficacy of our current practices. They've got us certain so far, and a wonderful distance, if you will, regarding hypertension control, but we're stuck, as we're going to see. And then we need to examine opportunities within that change to increase the hypertension control rates in our own communities, as well as our states and our country. Next slide. Well, here's the burning platform for the United States. And I think this was one of the impetuses for the CDC grant in our collaborative. In the height of the pandemic, a report came out. Our national data bank, if you will, and all of us know this, is called the NHANES data bank. It tracks diverse geography, ethnicity, and race individuals across our country in different disease states, including hypertension. Well, up until 2014, over about 3 or 4 decades of following data, now that we're treating hypertension, our control rates continued to go up. They would go up 2-3% every NHANES report. And all of us, including myself, said, okay, we're making progress. Everything's increasing. We can just continue to do the same. And eventually we're going to get to 80 to 90% where we need to be. Well, that didn't happen. In the 2017, 2018 survey, we got knocked over the head. And that was, not only did our control rates not go up, they went down. And they went down substantially, about 10% down to about 44% control rates. This was a time bomb. This was a bolt of lightning that hit all of us. And that was the burning platform, if you will, for that report. Remember, that was before COVID. We had not entered COVID. We have another interim report, and that has not budged. So we're still where we are in the low 40s after being in the mid 50s. That's using 140 over 90. But if we use the AHA-ACC criteria of 130 over 80, we would be at 20%. That would be fine if this was just a number, but it's not. It's outcomes. During the same period of time, we've noticed that there's been a plateau of the improvement of CVD morbidity mortality, and perhaps even a small increment adversely. And I heard someone mention stroke. Stroke is one of the bellwethers, would be the first one that outcome you're going to see. If things are going on the wrong side, follow stroke. And it's already going on the wrong side. So that is our burning platform. Next slide. So what happened? Well, the Surgeon General saw this data and saw the disparities in this data as well, which obviously the collaborative is key. It's central to. And in the middle of the pandemic, he initiated a call to action. He asked the CDC to all hands on deck. And this is the middle of COVID, and said, I need data, I need a report, we need to turn this around, and we need some novel interventions or novel thought processes. And that's what happened. This resulted in the Surgeon General's report, Call to Action on Hypertension in 2020. You can go on .gov and see the whole report. There were 3 goals, but the key was the goal number 3, which was change. We need to change what we're doing, our practice at present. And the committee recommendation, strategy number 1, was we need to advance the use of standardized treatment approaches, which are recommended care, including hypertension formularies and a standardized treatment protocol on a population-based level. That was groundbreaking. That was right out of the HARTS playbook. Of course, remember the CDC was one of the initial founding partners of HARTS, so they knew all about HARTS. You could take that out of any of our documents of HARTS and we could just cut and paste them. That was amazing. Next slide. So this is what we're talking about. In one lifespan, mine, in hypertension, we have gone from no care, where we didn't have evidence that lowering blood pressure made a difference. And if we did, we wouldn't have had the therapeutic agents anyway, to step care, which was the first evidence that lowering blood pressure improves cardiovascular morbidity mortality. And that consisted of one size fits all. One agent for everyone, a thiazide or thiazide-like diuretic, single therapy, monotherapy, titrate the dose up over whatever time, add a second if you needed to still lower blood pressure further, titrate that one, third, fourth, whatever. That gave way in the 1980s to where we are now, to individualized care. But this is just a fancy step care approach. What individualized care says is that you can still use one medication once the diagnosis is made, monotherapy, but you can use one of maybe 3 classes of agents, but still titrate that one up, start a second one, titrate that one up, etc. That's not working. It got us so far. It got us to the 50-yard line or the 45-yard line, if you will, on the opposite side. However, what we're proposing and what HARTS is all about is a paradigm change, taking all of the things that we've learned, but putting them into a population-based approach, which is, again, what we're going to discuss, where we could develop a program that we can export anywhere, any county in South Carolina, any state in the United States, any country or region in the world. And it will work. And it will work the same in all of these populations. Or it wouldn't work if it wasn't a population-based approach, if it didn't work in everybody. Next slide. Well, this is where HARTS began. It began in around 2010, 2011 by a small group of individuals, leadership from CDC and from PAHO, the Pan American Health Organization of the WHO Health Organization. Those deliberations culminated with a meeting in Miami in 2013, which I was honored to attend and be invited to attend. So I've been fortunate to be at the very, very ground level of HARTS in its development. We call that the Miami meeting. There was a subsequent meeting in 2014 where we started thinking and putting stuff on paper. But really, the breakthrough was Barbados, small country in the Caribbean, raised their hand in the meeting and said, we're in. We'll try a demonstration project of HARTS, what was then HARTS. And they did. They were soon followed by Cuba, Colombia, and Chile. Those were our first 4 countries. The first publication was 2016. It wasn't HARTS at that time. It was called the Standardized Hypertension Initiative Program. In any event, that morphed into HARTS. Next slide. Well, where are we now? Look at this. From a demonstration site in Barbados in 2016 to this. We now have 33 countries implementing HARTS in the region. This is just in PAHO's region, where we can talk globally as well, because HARTS is now global. As you can see, 33 countries, 1,300 primary healthcare clinics have implemented HARTS, and more than 5 million people are now covered. You can see the map showing the diversity of size of countries, geography, ethnicity, race, etc. I just got back from Mexico, which had been implemented HART pre-COVID. They just wanted a checkup, if you will. So it's been a week there in Mexico. But you can see big, small, little. We have 33 countries, and there are more now clamoring to join. There's a reason why there's this involvement, and it's because I'm going to show you the program and the data. It works. Next slide. These are the pillars. There are 6 technical pillars of HARTS. Clearly, the vision of HARTS is to become an institutionalized model of care to address cardiovascular risk management, secondary prevention, et cetera. By 2025, we've already passed that, and we're not even at 2025. The pillars are, and you're going to hear this repeatedly, it's inculcated in everything that I'm going to show you: standardized treatment protocols and medications, blood pressure measurement that follows regulations and validated devices, of course, extensive training and education that's available and easy and free, data standardization and innovation, and of course, then implementation research and program evaluation, and then again, team-based care and a primary care-based model. Next slide. So there are also guiding principles, some broad guiding principles that includes ownership, whether it's an individual clinic, a health system, a state, a region, or countries. There has to be individual ownership or it won't work. And that's job number 1. It has to be simple and practical. HARTS is. Evidence-based, of course. It has to be accountable. It has to have continuous learning, which it does. And it has to have long-term sustainability. We've already demonstrated it's sustainable for 11 years. And it's not only sustainable, it's still increasing. And by default, since it's a primary care population-based initiative, that also brings in our subspecialists as obviously key stakeholders, it has to also concomitantly increase the primary healthcare capacity of wherever we're delivering HARTS because it's primary care based. Next slide. So what's different? On one side, you see the traditional model, specialty based, physician-centered, non-standardized, blah, 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 discretionary use, etc. To the HARTS model, which is primary care based. It's team-based care where it makes sense and task shifting where it's allowed, of course, and appropriate. Standardized and focused on standardized care, et cetera, standardized clinical pathways and treatment protocol. That's key. We're going to go over that over and over again. Adoption of standardized blood pressure measurement techniques, including making sure we're using validated devices, standardized, simple, directive, and timely protocols, using pharmacologic agents, 2 medications at once, as we're going to talk about upon the initial diagnosis, not 1 anymore, and integrating, obviously, into a standardized and focused CVD secondary prevention, and inculcating and embedding cardiovascular risk assessment into the model. Next slide. So before we even talk about the model, what are some characteristics of high-performing health systems? We know this. There are many, many, of course, but there are three here that have been clear for hypertension and hypertension control by some high-performing health systems, including Kaiser Permanente in California. High-performing systems identify key drivers that rapidly change and result in the outcomes that they're looking for. In this case, it's increasing hypertension control. They translate those key drivers into process measures. It makes no difference if you can identify the drivers if you don't translate them into process. And more importantly, they measure it. So they give performance feedback to frontline clinicians and clinics on a timely basis. And as you're going to see, all these are components of HEARTS. Next slide. We owe Dr. Jeff Bretler a debt of gratitude. Jeff is the hypertension leadership at Kaiser Permanente in LA, but also now has gone over to their new medical school, the Kaiser Permanente School of Medicine. And he convened a large group, diverse group of experts, and just recently identified the key drivers for increased hypertension control. And this is now published. There were 5 domains noted: diagnosis, treatment, continuity of care, the delivery system, and of course, systems for performance monitoring. And out of those domains, they identified 8 key drivers that rapidly increase hypertension control: measure blood pressure accurately, CVD risk assessment. Why? Not only is it's important for overall patient care, but it makes a difference because many of our guidelines for treatment thresholds and targets are modified according to risk. Standardized treatment protocol. I'm going to say that over and over and over again. Treatment intensification, that's timely. Continuity and follow-up. Team-based care and task shifting. Again, we're allowed and we're appropriate. Medication refill frequency. Once patients have been stabilized and under control, no more 30-day refills. We need to go to 90-day refills. The evidence is clear. It makes a difference with adherence and obviously performing measures and systems for monitoring. All of these key drivers you're going to see are embedded in the HEARTS model, and as we're going to talk about very soon. Next slide. And that's this. This is it. On one piece of paper, whether it's a postcard, a postcard in your wallet, or it's a piece of paper at your computer, or it's a big poster on the wall, it's the hypertension clinical pathway. Dr. Andres Reséndez from PAHO led a group that I was fortunate to be on to develop the initial hypertension clinical pathway that's seen here. We're already into a hypertension clinical pathway 2.0 that we just recently discussed in Mexico. However, this is the core. It takes in those 8, if you can see those 8 domains surrounding the clinical pathway, they're all inculcated in here. And the pathway then is one population-based approach, if you will, with, of course, local ownership and local input and, of course, validation and acceptance. Let's go through the hypertension clinical pathway with a little bit more granularity. Next slide. Thank you, Kathleen. Well, the first component is component A and component B. As you can see, A is accurate blood pressure measurement, and B is cardiovascular risk assessment. Next slide, Kathleen. It's going to be just highlighting some of this, Pete. One key is measure blood pressure in all adults at all visits. My own institution, led by Dr. Mark Schaefer, has just gone through this, and it's tough. However, it's in here. Next slide, Kathleen. And also, wherever possible, and in our situation, it should be 100% possible, use automated oscillometric devices that are validated, obviously. And of course, it shows the patient and the proper techniques for taking a blood pressure. Next slide. Now, cardiovascular risk. Thank you, Kathleen. Since it's going to be inculcated in some of our decision-making, we need to assess cardiovascular risk for many, many good reasons in everybody, but specifically in our patients with hypertension. And the poster even has a QR code where you can just take your phone and scan, and you're going to bring up the cardiovascular risk. That's country individualized from PAHO, but it doesn't matter which one you use. We determine cardiovascular risk in everybody from the get-go. And this could be laboratory-based, preferably, or non-laboratory-based if laboratories are not readily available. The Framingham study, of course, is a prime example of a non-laboratory-based risk calculator. So use whatever we can use. Next slide, Kathleen. It also then goes to what the heart of hearts, if you will, which we deem the treatment protocol. And that is, as you can see, immediately after confirming blood pressure, don't wait. Start pharmacologic treatment. Start pharmacologic treatment at a blood pressure of 140/90 or greater in all hypertensives, but a systolic blood pressure of 130 in high-risk individuals. Those, of course, with established cardiovascular disease, diabetes, CKD, and of course, that have a high risk assessment of greater than 10%. And that's where cardiovascular risk directly comes into play. In addition, we also have targets. Since the treatment thresholds are different, the targets are different, and they follow. Less than 140/90 in all hypertensives, but less than 130 systolic in those that we just mentioned, the high-risk individuals, including those with existing disease. But it also reminds us aspirin daily in those individuals where it's appropriate, and moderate intensity and high intensity statins. It's even more dismal, the rate of aspirin use, appropriate aspirin use, and statin use in our country, let alone around the world. Next slide. And this is the crux. This gets to the heart of hearts, which is a standardized treatment program and treatment protocol or algorithm. This is just one example. However, the example holds and can be modified according to local availability of medications, et cetera. But there's core principles here. Number one, start with 2 medications upon the initial diagnosis. Start at half maximal doses of each and choose complementary classes of antihypertensive agents. We recommend a long-acting ARB and a long-acting CCB amlodipine. As you can see, this example is telmisartan and amlodipine at half maximal doses of each. 40/5. Bring that patient back in a timely fashion, 2 weeks, but no longer than 4 weeks. If the blood pressure is still not under control, double them each. As you can see, that step. Bring them back another 2 to 4 weeks. If they're still not controlled, add a thiazide or thiazide-like diuretic at half maximal dose. This example is chlorthalidone, and double it again. You can develop further steps if you wish locally and/or refer to the next target level of care. Let's highlight some of these. Kathleen, next slide. That's just going to say that I frequently get asked, well, what about lifestyle modification? It's absolute. And it's commensurate with pharmacologic therapy. But we don't do them in series. We do them in parallel. But it's clear. As a matter of fact, one of the technical pillars of hearts is H for heart, healthy lifestyles. And there's a whole pillar, if you will, and technical package around lifestyle modification. Next slide. And again, Kathleen. This always reminds us to repeat the measurement and also timely return visits and intensification, as we're going to discuss further. Next slide, Kathleen. So why the emphasis on starting 2 medications at once at half maximal doses? It's clear. I was asked to convene a group, and I did, of experts around the world, and we published several papers that we can share with you. However, there's tremendous advantages of starting 2 medications. Number one, as we're going to discuss at the end, start with the end in mind. Most patients with hypertension are going to require 2 or more antihypertensive medications anyway, especially as we're lowering the targets for blood pressure reduction. So why not start with 2? There's some people advocating 3 and 4 on the initial step. We're not there, but at least let's start with 2 medications, half maximal dose, complementary classes. There's greater efficacy of starting 2 together. The 2 together allows lower doses of each and actually lowers the blood pressure to a greater extent than the full maximal dose of either of those individual agents that was with step care and individualized care. Clearly better adherence is achieved. That's documented over and over and over again. So if we're going to talk about adherence, let's do things that improve adherence, rather than just talk about it. It reduces clinical inertia. The problem is us, in terms of not intensifying treatment when appropriate. And this is what's critical, especially to the collaborative, is that when you use complementary classes of antihypertensive agents together, you lower blood pressure equally across all demographics that we have studied. It's across race, it's across ethnicity, it's across age, sex, socioeconomic income, etc. And that's the basis for a population approach to treating hypertension. So if you take hearts to Barbados, 98% Black, and then you take it to perhaps Buenos Aires in Argentina, 98% European or European descent, they lower the blood pressure the same. That's amazing, and it's key. And of course, there's long-term benefits when you reduce cardiovascular outcomes. Next slide. This is ours. This is hot off the presses. Tremendous kudos to Dr. Mark Schaefer at our institution at Prisma. We introduced hearts. Emily, thank you very much, Emily, for the role you played in this initiative, where we did the same thing in Prisma. And this is our protocol that a group got together, convened, and owned and signed off on. And here's ours. It parallels very much what you just saw, but it's different agents because it's what we have. It's what we have, and it's available, et cetera, affordable, but it's the same. It starts with a half maximal dose of a calcium channel blocker and an ARB, in this case, amlodipine and valsartan. It doubles it if the blood pressure is not controlled. It adds a thiazide diuretic or a thiazide-like diuretic in a stepwise fashion, as you can see. We also developed a second protocol that Kaiser Permanente also has developed for women where there's pregnancy potential, or those with pregnancy potential where you cannot use renin-angiotensin inhibitor, an ARB or an ACE or spironolactone. As you can see, there's a parallel protocol for individuals such as those. But still, the premise, the guiding principles stay the same. Half maximal doses of two complementary agents, in this case, a calcium channel blocker, amlodipine, and a thiazide or thiazide-like diuretic. Next slide. And then finally, the hypertension clinical pathway concludes with follow-up periods and also reminds us about vaccinations. Next slide, Kathleen. And it'll highlight some of these. There's our follow-up advice, 3 to 6 months, depending on cardiovascular risk. Next slide, Kathleen. And we now know the tremendous importance of vaccinations regarding chronic inflammation, cardiovascular disease, et cetera. Last slide on this one. And this is the summary. The clinical pathway is the fundamental tool of hearts. It's on one piece of paper or one poster. And regarding implementation and recommendations, it adheres to the World Health Organization hypertension guidelines, which I was again honored to serve on and served as the co-chair of the writing committee, as well as the clinical drivers for hypertension that Dr. Bretler's team developed, as well as it parallels all major high blood pressure guidelines, including ours in the United States from the ACC and AHA. There's very, very little wiggle room between what the vast majority of guidelines and the heart package addresses. Next slide. Well, let's conclude. In addition to the protocol, our institution also, and Dr. Schaefer's group also went on to develop and utilize our EMR to develop a new hypertension smart set that helps our professionals, which incorporates the new hypertension algorithm into primary care, and also includes rapid return visits, including nurse blood pressure visits and dosage titration in conjunction with other professionals, whether it be a physician assistant, nurse practitioner, or a physician. And I guess makes secondary workups also easy. So this is critical as well, but not as important as starting with the standardized protocol. Next slide. And we're getting there. Well, what about results? Where are we? I showed you how many countries. Well, are there people? Or is it just countries on a piece of paper? No, these are people. This is the last data set that Dr. Dunes, who's the leader of hearts at PAHO, just shared with me 2 weeks ago and gave me permission to show. Between June of 23 and December 23, 6 months, there's been an 18% increase in individuals with hypertension that are now under treatment, according to Hearts and the Hearts package and protocol. 42%, an increase of 3% of people under treatment among the estimated people with hypertension. That's coverage. And it's interesting, the hypertension control rates did not increase over this 6-month period. However, look how high they are. 60% hypertension control rates. Ours, I just showed you, is 45%. And in Latin America and the Caribbean, at baseline, it's 30%. And this was rapidly achieved. And hopefully it will continue to go up. This translates into real people. that are now under control and under treatment and reducing cardiovascular risk, including and not solely importantly stroke, because that's what we'll see. That outcome is what we'll see first. Next slide. And we're almost done. What about the Global Hearts program? Well, Hearts in the Americas did so well, Geneva took it over and developed the Global Hearts Initiative, which is the same. We're now up to 23 million people under the Hearts. And this is shared to me by Dr. Andrew Moran from Columbia, who's with Resolve to Save Lives, and is championing and leading the global initiative with obviously WHO officials. And there's 44.7% individuals now that are under control. Remember, I said that the global rate is 20%. It's double. These are real people. Next slide. And this is just the latest. Dr. Moran said I could show this too. It's from Bangladesh. Bangladesh did a controlled study, 7 Hearts facilities and 7 usual care facilities. And the bottom line is the Hearts facilities that rapidly adapted hearts over a 6-month period dramatically decreased the systolic blood pressure overall between the 2 clinics of about 4 millimeters of mercury, but more importantly, significantly increased hypertension control rates to 62% in the 7 Hearts clinics versus the usual care clinics. Wow. Next slide. So tell me, why aren't we doing this? Because we are here now talking about it. So let's close with some thoughts. I've always been taught when you start a new program, whether it's a clinic program or a large program such as Hearts, start with the end in mind. Well, what's the end we want? The end we want is to increase hypertension control, and the goal should be 90%. Kaiser Permanente has achieved 90% control rates by using the concepts that are now embedded in Hearts. Why does it work? Well, it's comprehensive. It's evidence-based. It's a population and primary care-based approach where almost all of our hypertension individuals live. It's aligned with the major hypertension guidelines, and it has proven success, even within a short period of 10 years. It stresses the importance of appropriate measurement of blood pressure, cardiovascular risk assessment, and the use of standardized treatment algorithms. It also stresses the importance of timely patient follow-up. If you don't see the patient back in a timely manner, what good is it? Rapid medication titration when blood pressure is not under control, and as follows. And it also details the hypertension clinical pathway and incorporates the clinical key drivers to increase hypertension control. Next slide, Kathleen. Well, thank you very, very much for having me from South Carolina here in Columbia. As Emily said, it's really, really hot. So if anybody wants to invite me to a cooler place, please send an email. It's a pleasure to be with you, and it's really, really an honor. Thank you very much for having me.
Thank you so much, Dr. Tepeti. That was a great presentation, very insightful. And I think one of my main takeaways from that is just how fast that Hearts model can impact outcomes. Some of the data that you showed in just 6 months, there was a turnaround. So that was really impressive. Thank you for sharing that.
Maxine, you will see hypertension control rates increase within the first 3 months.
Wow. It's amazing. And this model is a model that we are adapting and using as part of our toolkits for other parts of our program. As for the Regional Collaborative or Learning Collaborative, participants from that will have a toolkit for the Hearts model to incorporate in their practices. Yep.
Also, Maxine, we are well aware, and I'm proud to have been involved in many of the toolkits we already have. From the AHA, Million Hearts, et cetera, from the AMA, Target BP, the MAP program. They are wonderful, and they're complementary. So it's not to replace. If organizations are already having success, by all means, keep doing it. However, if this can supplement, help, aid, and or start, then that's where we're asking everybody to entertain it.
Yeah, absolutely. Thank you so much, Dr. Tepeti. We want to use this time. We have 8 minutes left, and I just want to be mindful, but I just want to open it up for any questions or discussion points that we would like to take this time for.
Yes, I am Jimmy, Dr. Tepeti. How are you today?
Hi,
So,
Jim.
quick question. Is there, when it comes to African Americans and doing blood pressure, hypertension,
Yes.
there is certain medication that works for African Americans better than the medication that you may be giving to a Caucasian person.
Yes.
Can you kind of tell me how that comes into play and why is that so?
Jim, it's absolutely essential. And there's solid scientific basis for this, and the check is in the mail for that question. I'll pay you for that question. Yes, that's the difference between individualized care and then a population-based care. In individualized care, you use one medication in that hypertensive individual that's newly diagnosed. And when you use one medication, you're absolutely right. We know there's clear differences in blood pressure response rate based on race, genetics, and ethnicity, most prominently in our Afro descent, our African American Black patients. For instance, we know that blood pressure will go down with one agent if you use more in Black individuals if it's a thiazide, a diuretic, or if it's a calcium channel blocker. And we're talking about as one agent. We know it'll go down markedly less if you use a renin-angiotensin system inhibitor, such as an ACE inhibitor or an ARB. Clear distinctions. However, the beauty of HEARTS and the beauty of the standardized protocol on a population-based approach is once you use an agent from both of those together, you lower the blood pressure the same in everyone, because now you're using two complementary medications of differing classes, of complementary classes. And that's why the standardized protocol using two medications from complementary classes in the very, very first step is so critical, because it addresses that difference. You no longer have to worry about that. You no longer even have to talk about that, because we know that blood pressure will go down now equally in whether it's a white person, a Black person, an Asian person, a Hispanic person, or a European descent person such as myself. It'll all go down the same. And there's a beautiful study recently published by Jeff Bretler, which showed the exact same thing in inner city, Black population, in the barbershop study in California, showing that they almost equalized the hypertension control rates between Black and white individuals using the HEARTS approach and using the two complementary classes as initial therapy. Does that help, Jim?
It does. And my other question is, and I'm sorry, I don't want to take up all the time. The other question is, I know some people of my race that may be on blood pressure medicine. They take it 3 times a day. It could be because of their lifestyle, or it just could be genetics. How can we come to a census to control that instead of taking 3 pills a day and coming down to maybe 1? How can that be done?
By follow, absolutely, Jim. Again, there's going to be a second check. There is no need to take more than one antihypertensive medication from each class once a day, because we now have safe, effective, affordable, and available once-a-day antihypertensive agents within each of our primary guideline-based classes. And then the protocols with HEARTS that you've seen, it's only once-a-day agents. All of those protocols, whether it's the PRISMA protocol or the HEARTS example with telmisartan and the calcium channel blocker, it's only once-a-day agents. Tremendously improves adherence. And then the question becomes, does the time of day matter? And it does not matter what time of day the individual takes the once-a-day pill. They could take it at night or in the morning, lifestyle, they do shift work or whatever. It's still only once a day, and they can take it whatever most convenient time of day that's convenient for them.
Thank you, Dr. Tepetti, and thank you, Jimmy, for those great questions.
Thank you.
Jametta, yeah, thank you. Jametta, I saw that you unmuted yourself. Do you also have a question?
Yes. So the data looks great, really strong and impressive. But what is your message after you share this data, let's say with a provider or provider group, and they still, choose not to adopt? What is it that you're saying to them?
Well, the first thing is we don't give up. And that's normal. Remember, change. Remember Cotter. The first thing to change is you gotta be consistent and announce from the mountaintops the burning platform. So we keep reminding them of the burning platform as new data becomes available. Again, further enforcing the proven success that we've already demonstrated. We show it to them, discuss it, go back, have another podcast, have another webinar, have another IECHO series, et cetera, and don't give up. On the other hand, though, with a small initial, if you will, reticence on the HEARTS program from the early implementation. It predominantly came from the specialists, not the primary care individuals. That was very fleeting, that resistance, because once they put the protocol in place and they started using the protocol and the medications, et cetera, they saw the results rapidly. And then that further cemented that. And now it's role reversal. We have countries that want to join HEARTS rather than we are going to countries and asking them to join HEARTS. That will happen. But like everything else, where this is a rather dramatic change. It's not changing the agents we use, the pharmacologic doses, et cetera. It's just changing our pattern, our treatment paradigm, I'll use the word prejudices, but I don't mean that in a bad way. Biases, if you will. Does that help, Jametta?
Yes.
I mean, how about Barbados? Barbados is 98% Black. And they have just dramatic results with HEARTS using the exact same protocol that they're using in Buenos Aires, Argentina, or Mexico City with 98% Hispanic or indigenous genetics and bases. Doesn't matter. And globally, I showed you Bangladesh, Asian, Indian, population, same results. Doesn't matter. We have got to get this message across.
Wow, thank you. Great questions, great discussion. I really appreciate this. We are at the top of the hour. So thank you again, Dr. DePetty. This presentation will be available to everyone, and the presentation from Dr. DePetty will be available on our hub, our ECHO hub as well. Our next session is Thursday, July 25th, and it will be a presentation from Dr. Lackland on the American Society of Hypertension. If you want to submit a case review prior to that session, please go ahead and do so. Kathleen, again, will be sharing out that link to you in that process. Thank you all again for joining us today. We really appreciate your discussion. And again, thank you again, Dr. DePetty, for your wonderful presentation on HEARTS.
Well, Maxine, you're very, very good. You're welcome for sure, and everybody's welcome. Another possibility also to start getting this cemented is to have workshops, and I will gladly come with time available.
Yeah.
And that's what we did with HEARTS. We had independent workshops, hands-on for 2 or 3 days, and just pounded away at it and just talked.
I love that idea. We might be taking that up from you. So yeah, thank you again. I think we have a question.
We had one question. Erica asked if we would be able to send a reminder of session 1 week prior to the next session.
Yes, we can go ahead and send that reminder.